I'm Dr. Barton Branstetter. I'm the Chief of Neuroradiology here at the University of Pittsburgh Medical Center, and I am a professor of radiology, otolaryngology, and biomedical informatics here at the University of Pittsburgh.
I'm Steve Hasley. I'm the Program Director for the Clinical Informatics Fellowship at UPMC. Today we're going to talk about imaging informatics. And I am very pleased today to have with us someone who literally wrote the book on clinical imaging informatics, Dr. Barton Branstetter. Dr. Branstetter, thank you for your time and being with us today.
Oh, it's my pleasure. I'm glad to have a discussion with you about this interesting topic.
Terrific. Informatics has changed a lot of stuff at medicine, but maybe hardly anything as much as it's changed imaging. How did this all happen?
Well, of all the areas where informatics has had the greatest impact in medicine, I think that truly it has been transformative for radiology. We've come now to recognize that it's not just radiology that benefits, and that we've stopped using the term radiology informatics and started using the term imaging informatics, recognizing that imaging informatics affects all different specialties within medicine, but it's been absolutely transformative in radiology. We can see that in the way that we perform everyday tasks in radiology. Like you said, we've moved from film to an entirely digital environment, and it's absolutely changed everything we've done.
Rob, what do you think of when you hear the word PACS?
I pretty much just think about radiology, and that's about where it ends.
Well, there's so much more to it, right? There's PACS, and PACS has all these different parts, and I think for an informatician it's going to be absolutely critical to understand not only the PACS and how all of its parts interact, but how that system, the picture archiving and communication system, interacts with all of the other information systems that are throughout the hospital. When you use display monitors on the wards, you have relatively low expectations for those monitors. But when we need monitors in radiology, they are completely different. I can't tell you how often my clinical colleagues come down to review films with me, and we look at an image and they say, I couldn't see that at all when I was working up on the floor. And they're right, you couldn't see that at all. I couldn't see it either. It's not the expertise there. It is truly the quality of those display monitors that allows me to make my diagnoses. There's other demands in networking and storage that are way beyond what are needed in the usual clinical realm, and so these need to be taken into account specifically within radiology.
Yeah, the storage in and of itself, I mean, you guys are talking petabytes really quickly, right?
We really are. We talk in terms of petabytes of data on a yearly basis. Certainly for an institution as large as UPMC, we easily get into that territory.
How does the PACS system integrate into the e-record?
Well, at a low level, it's using the same HL7 messages that you're used to throughout your RIS and throughout your HIS to communicate, but it is taking those and storing those in different layers within the PACS itself. There's a day's worth of conversation we could have about exactly how we build that data structure, how we use specifications like DICOM in order to ensure that the data structures, how those message systems and file structures like DICOM are agreed upon at a national or international level, and how these are all assembled together in different layers and layers on top of each other to produce the data structure we need in order to get this information around.
What about image capture these days? Think of film as a two-dimensional, but now you're going into three-dimensional with MRIs and CTs and reconstructing these images in all kinds of different ways. How does the informatics help you with this effort?
Image post-processing has absolutely exploded in the digital age. We used to think, at a most basic level, about a CAT scan being a computed axial tomogram, but we almost never think of them as axial anymore. Although we acquire them that way, what we do with them is tremendously complex. 3D visualization itself, the ability to look at something in 3D on a monitor, that's a commodity at this point. However, we're starting to move into other areas like 3D printing. Producing a physical object that a surgeon can hold in his hand and look at a representation, not just of a generic person, but of their particular patient, with that fracture displaced exactly that much, and plan how to fix those patients' problem with a handheld 3D model. We're moving towards other forms of quantification. For example, all of the measurements that we're used to making of tumors, well, those are going to seem passé when we go to full 3D analysis and understanding exactly what the volumetric changes are over time.
Yes.
These things that required so much manual intervention that they were not practical in the past are going to become routine for us.
So in other words, I can actually get a really good estimated fetal weight on my pregnant ladies now.
How about a fetal volume?
Yeah,
I'll give you
right.
that
Well,
one.
That would work. That would be okay.
So as a surgical resident, I find that ergonomics plays a pretty important role in surgery. Can you tell me a little bit about how it has a role in radiology?
Just as important as it is to you in surgery, it's critical to us in radiology. Like a lot of office-style workers, we spend our days in front of a computer. Even those of us who do a lot of procedures end up spending a lot of time sitting and with a mouse in hand. Ergonomics is absolutely critical to us. So we've actually done a lot in this arena to try and use what other people have learned about ergonomics and apply it within radiology. We have tables that move up and down over the course of the day, so I can spend half my day standing up with a mouse in my hand and half my day sitting down with a mouse in my hand. My feet have to be at just the right angle. Every 20 minutes I have to get up and look away from the computer. These are the sorts of things that keep me from getting the sort of repetitive stress that is so common in office environments. Radiologists are particularly prone to this sort of thing, so we've done a lot of work in this arena. We did a project a number of years ago here at UPMC in which we hooked the PACS up to a Connect machine that's meant as a gaming machine. But what it allowed the surgeons to do was control the PACS within the operating room without breaking sterility, because the Connect system could watch the gestures that they gave, and those standardized gestures would control the PACS. So they could go through and see exactly the anatomy that they were interested in without ever having to touch the computer itself.
That's really interesting.
So another way that informatics has been transformative in radiology is the workflow of radiology. If you consider what actually had to happen to that piece of film as it marched around the hospital and got lost 3 or 4 times, that's all completely changed. And it took us a long time to catch up in our workflow with the new demands of the digital era. What we did initially is we took all these fantastic digital tools and just plugged them into our own our old workflow, which left us completely inefficient. What we've learned over the years to take these hundreds of steps that we used to need in order to take a piece of film around and boil them down into half as many steps, and our efficiency has gone way up. That sort of workflow analysis is a critical element of the sort of things that informaticians have given to radiology.
Business process mapping. Yes.
It's all critical to us, absolutely critical. This has also allowed us to become much more efficient, and we can get through more of our day. Now, the downside of that, of course, is that it's distanced us from the clinicians that we used to work so closely with. And one of the challenges now in informatics and radiology is getting those relationships back together, communication models that will reestablish the close relationships that have been diminished as we have gone to a more commoditized version of radiology.
True. You mentioned DICOM as a standard for imaging. Tell us a little bit more about that.
So DICOM was developed to ensure that we had a uniform standard so that all the different PACS manufacturers were storing their images in the same way, and that these medical images that truly belong to the patients can be moved from one place to another without fear that the data will be in a proprietary format that someone else can't get at. So DICOM is really the format that we use to ensure that uniform standard.
I'm curious, how did the radiology group interact with industry? I think in a lot of industries, everybody wants their proprietary format, so that you have to stick with us because this is where all your information is, and no one else can use that format.
You're absolutely right.
How did you guys jawbone them into adopting a standard?
It was not easy for all the reasons that you've laid out there. That is exactly what the vendors want to do, is maintain a proprietary structure, because it makes the change management much more difficult if you ever want to leave for someone else.
Right.
You're absolutely right, and in fact it took a tremendous push from leadership throughout the imaging informatics community, and distributing that knowledge to the everyday users as well, the people who aren't informaticians, to ensure that everyone was on point, everyone was giving the vendors the same message, and everyone was telling them, if you don't have support for these standards, for integrating the healthcare enterprise, for DICOM, for all of the standards that the radiology community has come up with, we don't want your products.
I mean, on the e-record side, everybody's screamingly mad about interoperability. This system won't talk to that system. They don't store things the same way, and the vendors are dragging their feet about doing anything about this.
We were fortunate that radiology that produced informaticians early on in the scope of digitization, and so we had leaders in place ready to receive when the vendors came out with those products.
How about decision support in imaging? How can a computer or some informatics help you as a radiologist to make sure you're seeing what you need to see and getting the right diagnosis?
We think of decision support in a lot of different ways. On the clinical side, we think of decision support in terms of ensuring that the correct test has been ordered in the first place. That's where we start the clinical decision support. And as we move on to the radiologist's role, we certainly have decision support that goes into that in terms of recognizing the terms that we're using and providing us with potential educational material to help us arrive at a specific diagnosis. We also used computer-aided diagnoses in order to guide us to specific areas of the image, in particular clinical scenarios. And then taking that down one step further, when the report comes back, there's also another opportunity for clinical decision support in terms of, now that this diagnosis has come back, what sort of follow-up is necessary, what sort of imaging tests come next, what sort of further diagnostic tests are needed in this clinical context.
Radiologists, I think you were some of the first people to really, well, you were using dictation for a long time before anybody else, but you've gotten into voice recognition now, dragon type things, nuance. What's going on with that? How does that help you in your workflow?
Yeah, we've definitely gotten to the point where everyone in the hospital system is using speech recognition as a routine part of their day. But you're correct, the radiologists were the first adopters of that technology, and we still have some of the highest requirements. We really live and breathe our dictations, and it's particularly important to us to have that sort of support.
Structured reporting, I think, is so critical. Trying to make the transition between the narrative story that we're taught to think that way in medical school. The computer likes discrete data points, discrete data elements. What's going on with that in radiology?
There's a big push towards more structured reporting for a lot of the reasons that you're talking about. We want to be able to extract information in the long term from these reports in a big data arrangement. At the same time, we don't want to lose that narrative of a patient, because that really is that particular patient's story, and we want to remain patient-centric. So the question is, how can we balance these two needs between the patient-centric narrative and the big data quantification model? The answer is probably somewhere in natural language processing, and we're just scratching the surface of that now.
Yes. What do you think UPMC's strengths are in imaging informatics right now?
UPMC has been at the forefront of first radiology informatics, and then as it transitioned into imaging informatics. We were the first institution in the country to have a imaging informatics fellowship, and we have continually had a large role in the overall informatics community, both in the biomedical informatics department here and nationally in the imaging informatics arena. We've continued this approach with industry relationships, and we have ongoing development, including our Technology Development Center, which is just a few miles down the road, where every day there are 2 or 3 radiologists in the Technology Development Center to ensure that there's the right clinical context for the development that's going on there.
Wow. Sounds great. Any final thoughts you'd like to add?
Well, I think that in order for someone to be a strong clinical informatician, they need to see all the different pillars of informatics as it supports the medical community. And imaging informatics is one of those key pillars. So I think that is a critical element to the education of a clinical informatics fellow.
Dr. Branstetter, thank you so much. You've been very informative. I appreciate your time.
It's been a pleasure.